Hey guys, lights, camera, action. If you see this face, you know it is time again. Thanks for clicking this video. It might be of interest to you and some other people, so do share. If you wonder who I am, my name is Priscilla Kuma, registered nurse. I come from Ghana. I live in the US, New York State, where I practice as a registered nurse. I double as the lead consultant at USRN Pathway Consult, where we help you process your documents to transfer your credentials from the foreign school that you went to be able to work in the US. Yes, we help process your foreign education to match the American standard, to be able to use that to get your RN license and practice nursing in America. I know it's been your dream, so reach out to us at USRN Pathway Consult via email or the numbers on the screen as you see. And today, I have my very own colleague, Joel, and I go way back. We happen to be nurses. He is a nurse. He's been a nurse for close to 20 years. That's a lot of years, yes. And he's an endoscopy nurse, and that is different for somebody who's schooled in Ghana. We know there's no endoscopy nursing school in Ghana, but he's an endoscopy nurse. And today he's going to tell us all about his journey and how it all started and where he is and what he's currently doing. So yeah, let's tune in and see. Thank you all new subscribers from all the channels that you've seen my faces on. I'm really glad to have you here. Please watch my video and share with others. Thanks. So as I said to you guys, Joel and I go way back. He's an endoscopy nurse and he's going to introduce himself to us. So Joel, welcome to my channel. Introduce yourself to my viewers, please.
All right. Thank you very much. I'm glad to be on your channel today. Yeah. As the name goes, my name is Joel, and I've been a nurse for some time now. Yeah, and I work in endoscopy. So.
Okay. That's a simple intro. I know Joe has a long profile, and then he's gonna unleash them onto us one at a time. So I'm very glad to have you here. It's been a long time. You and I had two things in common. We schooled along the line in University of Ghana, where you came to study as a mature student. Then also we worked together somewhere back in the days in Ghana. So endoscopy nursing, to the best of my knowledge, there is no endoscopy nursing school in Ghana. So how did you build the interest? Let's go back to the interest first. What happened? What did you study? Can you take us through your nursing journey? You did general nursing and what?
All right. So in the year 2000, I started nursing school. I mean, nursing wasn't part of my dreams, my plans, but it came along the line. My parents thought I should do that because they needed somebody in the medical field in the family. And so, yes, I joined. And so after nursing, I found my interest in either emergency nursing or theater nursing. And so I didn't like the bedside thing. So right from school in 2004, I went straight to the operating room where I started working as a nurse. Prior to that, I've actually worked on the wards, you know, the usual rotation thing, building your experience over the 3 years of training. And so I started working in the OR. And then a year after that, I decided that, I think it's a good interest. So I went to the perioperative training. I went for perioperative training in Kpodo, the School of Perioperative and Critical Care. And I built that skills and knowledge and experience over there for 1.5 years. And then I came back to the theater now as a trained perioperative nurse. And so I've worked in that capacity for a number of years. I can't remember, but then the interest in perioperative came because I was working in some other hospitals. So I worked in Kpodo Clinic, I worked in Kpodo, I worked in some other private facilities. At the point, I was working in 3 different hospitals at the time.
I know that.
Yeah. And so, and when I was in Kpodo, I worked in endoscopy and I saw how the whole thing was going. So the interest started from there. And so coincidentally, I got back to work, my usual workplace, which is a military hospital, one morning, and we heard that, oh, we were going to be starting endoscopy in this hospital very soon. And they were looking for people that will train. And I know at the time, a lot of people didn't have much knowledge about endoscopy. Nobody knew what endoscopy was really. And I was fortunate enough to have had, the experience with my locums and so on.
Yeah.
And so I expressed that with my theater manager at the time. And then she also knew I'm someone who like playing with gadgets as well, so computer stuff and stuff. And so he said, "Oh yeah, Joel, I think you can do it." So I was nominated together with another person, and then one doctor. And so at 37, those times we had one prof, Prof. Darkon from Kolebu, Prof. Darkon. And he came down to purposely to come and train the doctors on the job, which is something is regularly done in the country, in Ghana, because there's no school like that.
Yeah.
So myself and the doctor and then the other nurse, we were in that training. And I know it was pretty new to them, but I've been working in endoscopy in the shadows, so I at least had some ideas. So that training, it was just 1 week we had that training. So now that training, the hospital was now planning to start endoscopy, and so I took it upon myself to go and train myself in endoscopy. And so I went to see one very, very gracious man I'll never forget in my life, Dr. Mante. Dr. Mante was then the head of postgraduate at the postgraduate college at the 37 Military Hospital. Very, very lovable man. And he's somebody that believes in empowering people. Wow. And so he said, well, Joel, if this is what you want to do, I would sign for you to go and have this training. Wow. And so I went to Kolebu. He approved my letter together with my theater manager. And then I had to go to Kolebu for 8 weeks. And so I was doing on-the-job training at Kolebu 8 weeks. And Kolebu was then the standard, like in endoscopy, because they had all the consultants, specialists, the nurses that were also trained on the job and all that. So I joined them and we were having the training. I would go to work. I was doing nights. I was on night duty at the time, so I'll finish and then I'll go. And it was fun, We saw a lot of things. We had trainings, and we thought at the time it was the best we were having. That was the foundation of this endoscopy in Ghana here. Then along the line, when we were about to start, my hospital decided to start endoscopy. They now got the Germans, because we were going to use German equipment in endoscopy. And so we had the company reps coming in with everything. And so I had training with the Germans. They also gave me very, very solid training. I mean, this was a one-on-one training that I had with them for some time. You'll be surprised. These Germans would come in passing by for a program, and they will come and catch me and lock me down and just take me through specific trainings in endoscopy. And then the interest grew more. And then we finally had to start our endoscopy. there was this other woman in Kolebu. We called her Auntie B. She's very, very experienced woman in endoscopy.
Nice.
And so she also mentored me many years. And when it was time for us to start, she came over to 37, and then we actually set up the whole unit from scratch at the military hospital. So, and I was the lead nurse at the time, because apart from that, I had attended some other trainings in minimally invasive surgeries and being a perioperative nurse too. I've had some knowledge and experience in this area. So I was given the role to lead that. So I was leading as the perioperative nurse in minimally invasive surgeries and then endoscopy as well. And so the interest grew more and more and more. I started training myself in a lot of other things, attending conferences, workshops, and the slightest opportunity I had, I made it. And then there was this time that I had to also go to South Africa to have my training. And so I was in the South Africa for training in minimal invasive surgeries for some time. And then when I came back, I had a very good friend in the UK who was a senior, actually. I mean, he's still a senior. And he was working in endoscopy as the nurse manager in endoscopy in the UK, in the University Hospitals of Leicester. And then he visited me in Ghana with, some interest because he had heard that Joel's now doing endoscopy.
Yeah.
And he said,
Yeah.
I said, wow, this is what he does. And we had some plans. And so quickly, he made an arrangement for me, very special arrangements, out of the blue. And I had to have some intensive training in endoscopy in the UK here.
Wow.
And so all along, there is nothing like a formal classroom training for endoscopy nurses. And still, we really don't have something like that. But what we have is organized trainings where skills and knowledge is imparted. And that is what it has been. So he arranged this for me, and then I had to travel to the UK. So I came to the UK first time, did 8 weeks training. Can you imagine that? 8 weeks.
Wow.
Very intensive training.
Intensive, yeah.
Yeah, at the University Hospitals of Leicester. When you come in to the UK as a foreign nurse, it's not just easy for you to start touching patients and all that. But surprisingly, along the line, I was just allowed to also work as a nurse under very, very close supervision because people, the staff had so much confidence, and some of the consultants had so much confidence in what I was doing.
Wow.
And so the skills developed like that over and over and over. So I had to come 3 consecutive times for this training. So the first session, 8 weeks, I came back another 6 weeks, and I came back another 8 weeks or something like that. So the first one was for basically observations, but it ended up being more intensive training. I joined some consultants, some nurse, some other trainees, doctors in endoscopy. We did all that. The second one, I came in for therapeutic, and so we had to do advanced trainings, like a continuation from where we started. And then the third one went a bit deeper in endoscopy. So each time I came and went back to Ghana, I had to improve upon things.
Yeah.
And we have a saying that a child who has never traveled before, the one that thought that the mother was the best cook.
Yeah.
Yeah,
The
and
mother soup is the best. Yeah.
exactly. So after my first visit and working in University Hospitals of Leicester and having all the training, I go back and realized that we were trying in Ghana, but there
Yeah.
was much, much, much more room
I
for
can
improvement.
relate. Mm-hmm.
And right from there, I started to improve upon the setup that I had at the military hospital. And military hospital endoscopy became one of the best hospitals in the country at the time. We did a lot of procedures that both diagnostic and therapeutic endoscopies we started. I had some very adventurous doctors there. One of them, Dr. Lat, very adventurous guy. A
Doctor.
lot of the things that we had to do, he had read about them. He had probably, just read or knew that there were things like that, but really hadn't done them before, really hadn't practiced them actively. But when I got there, I said, well, let's do it. He said, are you sure, Joel, we can do this? Oh, yes, let's do it.
Dr. Lat.
Yeah. So he is a very adventurous guy. So we ended up doing a lot of interventions. And I was all over the place, endoscopy. I said, okay, no, I can't be the only one doing this thing. And that's when I thought I should set up a small society of nurses. And so we came up with the Society for Nurses in Endoscopy and Minimally Invasive Surgeries, SNEMIS. And the whole idea was to put nurses that had interest in endoscopy and those actually working in endoscopy under one umbrella for knowledge sharing and skills development and all that. So yeah, that's been the journey, and it's gone on like that, and I gradually became known in the country
That was
because
what
of
I was coming to. In
because
case you
of
didn't know, my introduction of Joel was so weak. Joel is a big shot. I'm sure most of you have seen him on TV and all over the place on flyers and all. He's a big shot. I think he's the first, maybe the only, correct me if I'm wrong, the first endoscopy nurse.
where some people like us have said,
Okay.
some older people, but
People.
as I said,
You took it to the next level.
yes, exactly. I mean, you need to continue from where people have left off, and the exposure that I had in the international
Yeah.
scene
Yeah.
led to that, and we realized that, excuse me to use the word, there were a lot of rubbish being done
Yeah.
around the place, and somebody had to correct them, and I
Yeah.
took that challenge. Yeah.
Yes, you did. So we've spoken at length, and we did not say for somebody who is watching, who is a non-medical person, or a nursing student, or even a nurse, we did not say what endoscopy is, and we've said all the story about it. So basically, to a layman, what is endoscopy at all?
So endoscopy is a general term that we use for a kind of procedure, a medical procedure, where we are able to use some equipment to visualize the internal structure of the human body. And so what it means is that, as you can see me now on the screen, we can actually also look inside your body the same way.
Yeah.
And see if you have any problems there, anything that is probably giving you some discomfort or some symptoms that you're experiencing. Now, endoscopy can be done in every or almost every system of the body. If you start from the head, we can actually look inside the head of people and see their brains and see what's going on there. We can actually look into the eyes, at the back of the eye of people. We can look inside the nose and go down into the airway, the lungs and so on. We can go through the chest and look at the heart. We can go into, um, in fact, through the body and look inside the bone and see what's going on there. We can actually go to the joints, see. And and we do endoscopy almost everywhere. You look into through the mouth, you can look into the digestive system. That's right from the mouth all the way to the throat, to the stomach, to the intestines, all the way out. We can also look into the urinary system, where we look into your bladder, urinary bladder, and so on. And for the women too, we can go look inside, the vagina through into the uterus and the tubes and everything. So the technology has been really great. And so that's different forms of endoscopy. But
Yeah.
when you hear of endoscopy, generally, what is being referred to most of the times has to do with the field that I work in now, which is a gastrointestinal endoscopy, where we look into the digestive system, specifically from the throat to the stomach to the intestines, all the way out to the anal or the anus. We normally would do endoscopy for people who are experiencing some level of discomfort or other symptoms that are, with their stomach, their intestines, weight loss, and so on and so forth. Yes. So that's endoscopy in brief.
Wow.
Yeah,
That's
we also, yes. So as I said, so we can do that to diagnose problems, or we can actually also do it to solve problems.
yeah.
Yeah.
Yeah. So I'm sure most people watching will relate, because maybe people who have all type of ulcers, peptic duodenal, they tell them to do endoscopy most times.
Yes. Yeah. So the interesting thing is that the equipment that we use is, this quite long instruments. It's a very flexible rubber-like thing with a camera at the tip and some lights at the tip. It can be a bit uncomfortable, but it is not a painful thing, especially when we are doing the top one. So we have upper GI endoscopies and lower GI endoscopies, and the upper GI, we are able to look into from the mouth to the throat to the stomach, and then to the first part of the small intestine, the duodenum. And people have all sort of problems there, from gastritis to ulcers to cancers and to other medical problems. Unfortunately, there are a lot of people walking about, crying that they have ulcer, but they really don't have ulcer. It's something else, and it's only an endoscopy that is able to prove that yes, it is really an ulcer or something else. But because of the fear and the misconception that people have had, and unfortunately, some places that they have been to that things have not been properly done, they carry that post-trauma experience and try to discourage people from doing this very interesting and important test. We also have the lower one, which we're able to look from the anus all the way up to the large intestine. We're able to see the entire large intestine. And that's where we pick up a lot of the cancers, from colorectal cancers, which is killing a lot of people nowadays. We're able to pick them early and then remove them. Surgeries, procedures or surgery that otherwise would have been done in theater, or you cut you open, look for the problems, cut your intestine into two, remove the tumors and so on, and join it back. With endoscopy, we go without a cut, and we just pick out the cancers, from that point out, and it's really interesting. And we've had many more advancements. Now we have the capsule endoscopy, which is basically something like a capsule, that you just swallow, like you just swallow it like your multivitamin capsule.
Yeah.
And you go about doing your normal duties.
Mm-hmm.
You just wear a gadget on your body, and you still have your endoscopy done. Um, no pain or minimal discomfort or whatever. And so yes, so it's a very interesting area to venture into. Yeah.
So you want to throw more lights on colonoscopy? Have you
Mm.
Yeah.
Yeah. So colonoscopy is also a type of endoscopy. And earlier I mentioned that we have lower GI endoscopies, and so the lower GI endoscopy we have. First of all, let me start from the bottom, which is the anoscopy. Anoscopy is basically examination of the anus.
Yes,
So probably people that have things like hemorrhoid, skin tags, some forms of anal cancers, or
fistula and all that.
yeah, fistula. Yeah, we just do that, and we use a small scope called an endoscope to just examine there. A very short procedure. Um, from there, we go to what we call the protoscopy. Proctoscopy, which is going a bit further from the anus into the rectum. If you look at the anatomy of the lower gastrointestinal tract. So we go into the rectum, and then at the rectum too, we're able to detect similar things that I mentioned. Some people bleed each time they go to the toilet, or once in a while they bleed, when they constipate and so on. Locally, in Ghana, we have what they call cuckoo and so on and so forth.
House.
It's difficult to know if it's pals that they're referring to or something else, but medically, we say pals or hemorrhoids, and this is a big problem to a lot of people. And this is one of the procedures that we do to identify it and also treat it. So we go and then we do what we call banding. We are able to just catch the piles, tie it up, and then it stops. The problem stops after some time. Otherwise, it progresses and becomes a big issue that will require a major surgery for people. Yeah. And so after the protoscopy, then we have what we call the sigmoidoscopy. Sigmoidoscopy, we go a bit further from the rectum to the sigmoid colon, where we do the examination as well, using either a colonoscope or a flexible or a rigid sigmoidoscope. This tube is passed all the way into the sigmoid colon, and then we see the problems on screen. Just as you're looking at me now, we look inside your large intestine like that. So from there, then we have what we call the colonoscopy, which is the full examination of the entire large colon. And so the entire large colon is a very long tube, and so we spend some time examining it in detail. And so people that will normally need a colonoscopy are people that they've been having some lower abdominal pains for some time. They've tried everything, and we can identify the problem, and so your doctor may ask you to come and do that. Also, we have some people who begin to lose weight, unexplained weight loss. There are some of us that want to lose weight, but there are people who they're losing weight
unconsciously without trying.
Yeah, without trying. And so it could be a cancer or something sitting inside your bowel, eating you up. So they may ask you to do that. There are also people who see blood in their stool, as I said. You don't necessarily have to see the red blood. Sometimes it's dark and quite difficult to know. And so when you go to the hospital and they ask you to bring a stool or a stool, occult test, they identify blood in it. And so they want to probably do a colonoscopy for you to identify where the bleeding is coming from. Is it from a cancer or a polyp or what? Something. We also have people who have a family history of cancers, and they are also encouraged to do colonoscopy at some point. And fortunately, for us now in the developed world, from age 45 and above, it's recommended that you have a screening for colonoscopy, just as you would have for your normal medical screening. And I think this is a very laudable idea. It's been around for some time. This is a very important program that I was considering back home in Ghana, and I was pushing for, and I'll continue to push for it. That we encourage people from 45, because the colorectal cancers are, our race is already predisposed, to this kind of things. So people come in, most of the cancers that we see advanced because nobody thinks or considers the need for a colonoscopy. In fact, my MPhil thesis I did recently, I did it in the experiences of the elderly in colonoscopy. You realize that a lot of them didn't know anything about endoscopy. They ended up in the endoscopy suite for colonoscopy because they were having one or two problems. Just about 2% or so of them heard that they could have a screening colonoscopy, just as a medical screening. And if you trace those people you realize that most of them have their relatives, living outside and so on, and they were the ones encouraging them to go have those. Yes. Apart from that, everybody else that had a colonoscopy at the time went in for colonoscopy because they were either bleeding or having pain somewhere or something. So, and we will encourage people 45 years and above as a routine. When you're going for your medical screening, you can consider having a colonoscopy as well to pick up the cancers. Because the thing about cancers is that the earlier we diagnose it, the better the prognosis for you. If we diagnose it early, we can take care of it and it could be cured. Unfortunately, if you don't go for the screening early, you would not. And that could cost you your life.
This is enlightening. So if my doctor orders endoscopy for me, what are the basic prep? Whether colonoscopy, sigmoidoscopy, what are basic prep? I know they have to fast for some time. What should I do when I have to do an endoscopy of any kind?
Right. So the two types of endoscopies, which is commonly done, the upper GI endoscopy, also known as gastroscopy, has a very simple preparation. And then the lower GI, which is a colonoscopy or other forms of lower GI endoscopies, also have very simple and become a bit more complex preparation.
Brow prep.
Now, we'll start from the upper GI. So the upper GI, the whole idea of our endoscopy is for us to go inside your system and observe, and visualize. And so all we want is the place should be clear. The stomach is where we eat into, and food is kept there until it's digested and absorbed. And it can take some number of hours for that to happen. And so if you have to do endoscopy, depending on the time that you have been given an appointment, you may be asked to stop eating or fast, not have any food in there for a period of time. And so those who would go for morning appointments, they would ask you that you shouldn't eat anything at least between 4 to 6 hours, sometimes 8 hours, before you go for your endoscopy, upper GI endoscopy or gastroscopy. You could take some clear fluids up to about 2 hours before you go. That's for those who cannot withstand hunger, as they always say. We've had patients who say, "Oh, me, I have also I can't, I can't stay without eating anything."
Yeah.
Well, if you eat, you put yourself at risk of so many things, and that would include you trying to vomit and aspirate things, and you get choked. And so the choking can become very dangerous for you, especially if you find yourself in some endoscopy units that don't follow the safety regulations or simple safety things, having safety equipment there, like the suction machine, extra suction machine to, take care of your airways and so on and so forth. So basically, anybody going to do endoscopy, upper GI endoscopy, gastroscopy, we would ask the person that you're not supposed to eat anything at least 6 hours, before you go in. So for those going in the morning, we tell, okay, don't eat anything overnight again. And, sometimes it becomes way overboard where they ask people for 12 good hours not to eat anything. It's not necessary, unless it's a special case where your doctor specifically will ask that, okay, don't eat for that long. However, within 6 to 8 hours fasting, we should be fine. The stomach should be clear enough for us to see everything. And as I said, you can still drink some water or clear fluid. And when you say clear fluids, I mean any drink, of course, apart from alcohol, any drink that when you put in a glass, you can see through. When you put it in a bottle, a clear bottle, you can actually see through to the other side. So any drink like that, you can actually take up to 2 hours before your appointment time for your safety and so on. We have people like diabetics who would also need endoscopy. And so for those people, because of the fasting and because of the sugar level stuff, they need to always monitor their sugar while they are fasting. And if they are going into hypo or the sugar is going low, they may have to boost it up with some sugary drinks and so on and so forth. Yes. And it's very important for you to tell your endoscopy nurse if you have some allergies, to either medication or any other thing that you could come into contact with in the hospital. You need to come out clearly and let your doctor or your endoscopy nurse be aware of some of these things. Yes. So that's how you prepare for an upper GI endoscopy.